Brachial plexus. The purpose of our examination should be to find out if it's preganglionic or postganglionic. Also to assess if it's supraclavicular or infraclavicular. History is important. Take a detailed history. The mechanism of history can tell you which cords cords are involved. Start examination with the patient. Look at the eyes. Check for Horner syndrome, clavicle deformity, posterior triangle of the neck for any scar, pectoral major posture, arm posture like wader tip hand clawing and muscle wasting. Uh, on the side, check for supraspinatus, infraspinatus fossa. Uh, Behind, check for winging. Look for end scar in axilla region. Check for the dermatomical examination from up to downwards to the all the dermatomes. Uh, C3 is posterior aspect of neck, C4 is distally, C5 is at the lateral aspect of the shoulder, C6 is the thumb, C7 is the middle finger, C8 is the little finger, and T1 is near the axilla region over the arm. Regarding when you start motor examination, check for the trapezius muscle. Ask the patient to shrug his shoulder, lift it up, and feel it. It's not a brachial plexus muscle, but is important. The nerve is important for the transfers. Now, ask the patient to back squeeze the shoulder and feel for the rhomboids. Now, again, you can check for the scapular winging of the serratus anterior. Ask him to push against the wall. Then I want to check for the deltoid by abduction and check for the muscles fibers to be contracted. Then I want to check the supraspinatus muscle by Job's test. Then I want to check the infraspinatus muscle, which is by external rotator. Then I want to check for subscapularis, which is an internal rotation. Then I want to check the teres minor, which is external rotation in abduction. At this moment, I will go for elbow flexion and check for the bicep. Now I will check for latissimus dorsi by asking to push down on my hands. Then I will check for elbow extension, and then at the end I will do hand flexion and abduction of the fingers. Commenting on the brachial plexus, the brachial plexus arises from the ventral rami of the C5 to T1. They are divided into root, trunk, divisions, cord, and branches. They can be easily divided into supraclavicular region and the infraclavicular region. Talking about the supraclavicular region, any lesion which is above the division is pointed at supraclavicular lesion. The root lie in the posterior triangle of the neck between the scalenus anterior and the medius with subclavian artery. Three branches are important supraclavicular branches. Dorsal scapular nerve arises from C5, is supplying levator scapulae and rhomboids. The branches of phrenic nerve is not the part of the brachial plexus, but C5 root is involved. Long thoracic nerve is serratus anterior, which arises from C5, C6, and C7. Then going downwards to the trunk, there is suprascapular nerve, which supplies supraspinatus and infraspinatus, and the nerve to subclavius. Otherwise, then in the division, there is no branches. Now talking about the infraclavicular region consists of cords. From the lateral branch, from anterior division, musculocutaneous nerve arises, which supplies the brachial plexus, bicep brachialis and coracobrachialis, BBC. Lateral pectoral nerve arises, which supplies the major and minor. From the posterior cord arises axillary nerve and radial nerve and supplies the muscles. Then supplies the upper posterior cord also has upper subscapular nerve, which supplies subscapularis, and lower subscapular nerve, which supplies teres major. Then there is a thoracodorsal nerve, which lies between the upper subscapular and lower subscapular nerve and supplies latissimus dorsi. From the medial, the branches are medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm, and medial pectoral nerve, which supplies pectoralis major and minor. The end branches is the ulnar nerve and medial root of the median nerve.